and shark keeps them afloat. We go to play and have a look with Chewy's gags, Jim's dashing looks. The world wishes their views were tame, so Chewy and Jim just take the blame. Chewy and Jim, just get on with the show.
Welcome back to the Chewy and Rob podcast, in which Rob and Jim... No, that...
Leave it in. You've deleted me.
Right.
What is it?
I did want to. That's one of my wildest dreams.
Yeah.
Would be to supplant. No, it's the Jim and Rob podcast, because you've come up with an episode of which you're like, oh, we've got a great podcast. It's like, am I involved in this? Or if you want. So, what do you mean if I want? It's called Chewy and Jim. Like doing something for Physio Matters, we're a team.
You're the
Chewy
lead
and Jim,
character.
you think I'd need to be involved in that?
Your
It's not
name-
even in
your-
the theme tune.
No, your name's first as well, which is even funnier.
Rob and Jim.
Top billing.
Better than Jim. Yeah, I got it.
Oh, that works.
That works. It's tuneful as well. Right, anyway, so yeah, they tried to supplant me, but I clung on there because, of course, whatever they go on to say, even without preparation, I will weigh in on with an excessively vigorous opinion. So, what is it
Vigorous.
Go on, tell everyone what you were wanting to chat about.
Okay, so I want to discuss the challenges that come with being an MSK generalist. And some of those are related to rehab, some of those are related to diagnostic. I think that they are closely related but can also be separated on what you do in some of those situations. And they will obviously differ depending on where you sit, like how big your team is, what skills are in team, whether you're on your own and stuff like that. But this came from Rob and I having a bit of a discussion about some things that we've seen across social media and some posts, but also some discussions we've had with Physio First about creating some content for MSK generalists as well. And I have some concerns around things that I've seen and people basically having a go at stuff. And in some situations, I think that is dangerous. And in other situations, I think that's okay. But obviously, my opinion's not the only one that matters. Should be the only one that matters, but apparently my opinion is not the only one that matters. So I just wanted to have a bit of a back and forth about that, because obviously my bias being my clinical caseload being overly the other direction where I'm very specialist and I only see quite a small subset of patients. Am I boring you already? So dull, yeah. Okay, so
it's an interesting topic.
Yeah, so to set the scene, I think the two main...
Does it follow on from what we did in the last Chewy and Jim, where I went off on one about saying that, like, I should, as a generalist, I shouldn't be a second opinion. Does it link to that at all, or just because
a little bit,
but maybe
not...
the viewers would benefit from just having a little look
at that
at
previous
the first
one.
part of that.
Yeah, I think a little bit, but that was more around skill sets within rehab. I think this is more around experience and also just support networks.
Right. So give a couple of examples.
Yeah, okay.
That will help.
So the two main examples that I have are the patient has attended and you are making a diagnosis as a generalist.
Yeah.
And the second example would be where you're seeing the patient for want of a better turn of phrase, rehabilitation or treatment, and they have come with a diagnosis, but you as a clinician have not treated that kind of diagnosis before, or possibly an associated side-along issue, comorbidity, for example. So an obvious one on the diagnostic point of view would be someone attends with foot pain and you make a misdiagnosis because you've never seen, say, a stress fracture in a runner before. Whereas a rehab thing, Rob said about he's not got experience post-surgical. So someone comes post-surgery for rehab, say a knee replacement or an ACL tear, and you've not seen that kind of surgery before. And then having a go at rehabilitating those. Some things, and we can get into this, some things are safer to do that with, in my opinion, and other things are more dangerous. But it's about, does everybody, I suppose the contentious point is, are all physios born with that knowledge of where their ceiling is? Or do they have this sort of idea that they can have a go at some stuff.
So competency breaches that might affect safety, but then also competency breaches that might affect quality, and then those things interact a little bit. So, imposter Bevan, this sounds like a great subject matter for Chewy and Jim.
Yeah.
But what are you doing here? Why are you waiting?
I think the different angle that I come in from, and this isn't as a counterpoint, more as an addition, is that the route that the physios will take into practice is with a very wide, broad spectrum team on the whole. So for a patient to get to the physio in the NHS and to the access which you then have to other specialists, whether that's a respiratory specialist, whether it's advanced practice specialist, whatever it might be, that route that you have, you're very rarely in the NHS a solo person seeing a patient without any additional support. Whereas in my world, being that you graduate as a chiropractor, someone might graduate and then go into a clinic that they set up themselves, and they're seeing patients day one after graduating with no additional support. So then the mindset that person might have is very much I'm going to take everything on. I'm good at screening for red flags, and I'm good at knowing when, okay, this is within inside my scope, and I can manage that, and I can learn how to manage it. And I think that's the mindset that a lot of people have starting out, and that then probably goes to the physios as well. If they then open up their own private practice, it's the same route.
That's it's fascinating, because that's going to be an increasing challenge, isn't it, for graduate physios struggling for work, also those that want to subspecialise quickly, consider themselves technically, legally competent, but if they've not got a strong sense of, like, you don't know what you don't know, of course you don't, it's still challenging, isn't it, to get into that space. If you've not got a network, and you set up because you can. Just imagine the perils of a new graduate physio in this climate, and by that I mean there's a lot of undereducation, in our opinion, we've spoken about, especially off the back of COVID, as well as the variation that occur from various different new schools and stuff like that, quite a loosely regulated thing that we've weighed in on. They set up a neuro triage service, or they fancy neuro rehab. They had a nice placement. They'd love to see some patients in for neuro rehab and stuff like that. The dangers of that, if you're the first contact professional for that person, that's he's got a bit wobbly on his feet, or should his face look like that? It's like, it's like, I know I'm being a bit facetious there, but only slightly. Like, that is so dangerous. So I certainly follow the logic. Can I bring you in then on safety? What sorts of things do you think are obviously unsafe, where you feel like people are chancing it? And then if you can answer the next part of that, would be, why would they be taking that risk with their own professional integrity as well as someone's health?
So the obvious answer to the safety is red flag or sinister diagnoses. Obviously my specialty being rheumatology, and if you see an undiagnosed rheumatological patient and you try and manage them without the help of a rheumatologist, you're going to significantly delay care. Or if you see somebody with a stress fracture and you misdiagnose that as something else, you're going to prolong the issues there. Or if you see something, you miss cancer, for example, which everybody can. It's not, nobody's perfect. But I think that's the obvious safety components. The other issues, you alluded to quality. So the other issue would be something like, let's take ACL reconstruction. There are quite specific protocols that people need to meet. But my understanding of that is that you need quite a lot of skill and access to know that you've got someone through each component to go on to the next one. So take return to sport, for example, and with re-rupture rates being high, then it's quite a lot of issue there with those specifics. And I'm sure there is lots of other surgical and other diagnostic things in general practice that would meet similar criteria. So I think there's multiple levels to it. And obviously missing something like cancer is arguably worse than causing someone a re-tear on their ACL, depending on how you make that argument. So there are levels to it. Or taking someone from, they would have recovered from that stress fracture in 12 weeks, actually it's been 20. Depending on the individual, there are levels to that danger, but it's more, to me, it's less about that individual component of danger and more about the general reasoning process that people are going through. And I see enough social media posts that are like, I have this patient coming in with this diagnosis that I've not treated before. What do people suggest? And I don't think that's an appropriate support mechanism. And if they're and my concern is that that's the tip of the iceberg for that individual. And so what are they doing when they've seen one or two diagnoses?
Yeah.
And then they're going, oh, I saw.
It's not even met that threshold for them.
It's
to
not met that
grab
threshold.
help.
So what it's doing to me is I'm wondering whether there is this large number of clinicians at various levels of where is that threshold that don't have appropriate support, or don't know how to access appropriate support, that they are then causing extended delay or deteriorate or worse outcomes for patients, or missing diagnoses. And we are arguably aiming for educating the masses on generalized treatments. And I suppose it's that old argument, isn't it? A generalist versus a specialist. You probably want both. But if you are a generalist, I don't think you can take your foot off the gas on learning a lot of quite specific information.
You need to know when your generalist skills would apply appropriately to certain specialist diagnoses that might not matter beyond medical management. Rehabilitation might be indicated.
But I think if you go back to that social media post, people will often do that for very specific conditions. They'll question. And if you extrapolated that example and said, I've never seen an ACL tear before, they're coming in tomorrow, and they're going to be a week post-op, there aren't many people that are going to say, oh, do this. They're probably going to say, refer to someone who's seen this before. And that we don't seem to have that attitude. The attitude seems to be, I've never seen a patient with RA before. That was a fairly recent one. And you probably got more thoughts on this being your specialty, but there is that argument of how much does this overlap? And I think that's the idea which people need to understand is where's the overlap here? If you dealt with an acute gout flare-up, an acute OA flare-up, and you're fairly competent in that, and you know that this is an RA flare-up, I mean, that goes into the diagnostic certainty as well, but is there enough overlap in certain things? If you've dealt with all of knee ligaments, but you've never actually really seen an ACL and an MCL in the last couple of years, but actually you're very familiar with lots of other principles of rehabilitation and principles of stability and post-surgical management, there's some overlap there. But if you've never seen a knee, maybe, and you've only seen lots of spinal cases, then maybe you don't have a go
People
at an
sometimes
ACL.
will do that. I'm not much of an MSK physio, but
I've got this person coming in.
My sort of neuro rehab patient, he's got Parkinson's and he's sprained his ankle and stuff. It's like...
But the opposite of that is true as well. So one case that Rob and I thought about when we were sort of semi-prepping for this was, and Alistair Beverley does a lot of good education about this, what if you've seen a lot of stress fractures, but your patient has Down syndrome, for example? Like, where your skill set has to cover all of those things. I saw a patient relatively recently who has ankylosing spondylitis, and I wanted her to improve her diet quite significantly. Her diet was dreadful, but she's autistic. So I said, that's not you're outside of my skill set for that component.
Yeah. In order to inspire that behaviour.
Yeah, because that I happen to have knowledge of autism that most people don't have, but the that takes me to a place to go, I don't want to intervene in your diet because that could have other downstream effects because of your diagnosis that is completely irrelevant to your ankylosing spondylitis.
I know I've accidentally assumed this role because I was the third wheel, and I'm now interrogating you both on these things. But sod it, I'm here now. What? Because all of these examples I've made sense of and stuff, and I have my opinions on. I'll weigh in on in a sec. But what I'm fascinating about what you've just described though is that I'm surprised. Professionally, you're not an autism specialist, but you have personal insights onto autism and the management of autism in such a way that I'd be surprised if you wouldn't be in a position that your specialist area of rheumatology and the primary AS of which you are seeing someone, those behavioural aspects that might influence those dietary changes, I can imagine you wanting to make sure that then there's also some specialist input, but I'd also think that you'd be quite well placed to help with that person. So I was just thinking, like, are you not... I sort of sensed when you were telling that story, I was like, that seems like you're trying to stay in too narrow.
No, because I think that's where I have a surface level nutritional skill set. So I'm happy to say, I was going to use Rob as an example. Rob's actually a bad example. But if you came into my clinic and I thought, okay, your diet's not very good, I'd like you to try and eat a generally healthy diet, and we're going to try and hit this amount of protein. I'd be happy to do that. That's my surface level knowledge of nutrition within that rheumatological space. As soon as someone has other dietary impacts, whatever that may be, then I feel like because my specific knowledge of those things. So let's say I commonly advise higher protein diets in my rheumatological patients, but as soon as someone's got a kidney problem, I'm not doing that.
Sure, yeah.
That's out. So then it's outside of my skill set. But like, this is where I find it, and I don't know whether because I deem myself a specialist, I've drawn these quite solid lines for myself, and I go, this is my skill set, and anything outside of that, I either need support or I refer out. Do MSK generalists do that? Or is it so blurred that it doesn't exist?
I think it's interesting because you know, by temperament and disposition, you will create crisper borders and lines around stuff than I would, but famously blurring those things. And therefore, I think probably I do. But then I also recognise that is, I'm always having to sort of temper that by recognising those competency lines which are appropriate for onward referral, second opinion, running it by someone, creating a network. Rob, you famously sort of sit between us a bit on that in lots of ways. Yeah. But what I definitely want you to answer as you wish, but also if you could try and get us to why do you think people are getting so in over their heads on certain things? Then what mechanisms would make people put themselves and their patients at jeopardy?
I think probably where it comes from to some people is from a business sense, and it's the being a yes person, and you've got that lovely lady who you're seeing for some, generalized lower back pain. Oh, my husband's just tweaked his knee. Can you have a look at him? And you've got that relationship. Oh, he can't get into his GP. And it's the kind of probably that kind of altruistic nature that people have when they go into these professions is they want to say yes and they want to help someone. And my daughter's really struggling with these headaches. It's just an 18-week wait to see a neurologist.
Right.
Is there anything you could just have a go at doing? Those type of conversations are probably more. We can look at this from a helicopter type perspective and very much say, why would people do that? But then when you put on the spot and sort of say, can you do this? And maybe I know enough about headaches to, I can rule out some nasty stuff. Maybe there's some mechanical stuff I can rub and poke a bit, and maybe I can give her some stretches. Is there something that people kind of adhere to and latch to? But then it goes back to that diagnostic indicator of how certain are we in a diagnosis, and that particularly when it comes to things like headaches, like, are you confident enough in ruling out red flags? I don't see dizzy patients, because I can do. I was trained in it, but I haven't seen a dizzy patient outside of an acutely diagnosed BPPV that I can do it. Can someone do an epilepsy? I can do an epilepsy, in the mechanics of it, but that's not the difficult part. The difficult part is the advice, the guidance, the reassurance, all the other things that you go through with the patient, or the diagnosis in it. A dizzy patient says, what's going on? I might have an idea that it's BPPV in one of the canals, but I wouldn't be confident. TMJ?
Because some of what you described there definitely applies across the spectrum of MSK professionals. I think some of it is there are some chiropractors that are very spine specific, and I feel like that's one of the things that's interesting that you don't really have a physio version of, barring the hands or feet maybe, where someone that is competent at management of spines in an MSK physio sense is often as competent in knees, or at least is competent in knees, excellent at spines if they're a spinal specialist. But it'd be strange for that example you used with we have a look at my husband's knee would not be appropriate. The headache one's a great example across both, whereby some people just aren't au fait with that regardless. But I think that is an interesting threshold. On the why point, that business element definitely is playing a part, and that really concerns me. I think that the thing that the examples that Rob's given there's more of I think that's less of a clean ethical line where they are out over their skis, in over their head, whatever example we want to use for how they've ended up in that situation, and that they can bail themselves out of it ASAP, try a couple of things, and then they should have done differently, right? The ones that concern me, especially in private practice, is people being yes men and women at point of inquiry for something that they should have known better on. And we've seen examples on social media whereby people have got a new patient coming in, and we find out.
So you don't mean the diagnostic aspect? You mean they've already got a diagnosis and you're having a go at managing
or they're presenting with what they might even have a diagnosis and they might present him with a vagueness that sounds like, right? Or they're getting these weird symptoms they've told my receptionist, or I've told me on the phone, they're coming in tomorrow for a full examination, what should I do? It's just, it's sort of like someone's describing quite vague neurovascular symptoms of the face, and you're like, well, one thing you should have been doing is not taking their money. As a basic level, and regardless of the money, is like, are you the right person to assess them tomorrow compared to their GP?
And maybe
or A&E.
And it might also come down to how good do you think are you actually very good at neuro in terms whatever that might be? Do you back yourself enough from a cranial nerve examination point, from a neurological examination point, that you know enough to signpost, and you see yourself as that triage person wherever that might be? So it might not be that you're trying to treat them, but it's that I know that I'm the person today that they can turn to because they can't get into their GP, that I can say enough that actually you've got an objectively numb face here, this needs to be escalated. I can help you with a letter here or an emergency referral to get you where you need to be. And some people will come from that perspective. They'll come. I've had patients who have said, I can't get in to see anyone. Can you refer me to an orthopedic surgeon privately because I want to have a new knee and the wait list is too long, but I need a letter. They might not need a letter to get there, but they might think they do. Yeah. So there's another aspect in that.
Well, there's also...
And that's a whole different...
Yeah, there's also this aspect of... You said it well about transferable skills. So let's stick with the neurology part of it. Let's say you're an upper limb specialist and you're very competent at neurological disorders of the upper limb, and someone goes, I've got pins and needles or even MSK, entrapment neuropathies. I've got a numb, tingly foot.
Sure.
You could transfer. You're not a specialist. I don't particularly have an issue with that. And then if someone goes, I'm an upper limb specialist with neurological experience. Is there anything I should consider extra in the foot? Like, that's a very different question to what I think. And like I said, the main concern for me for this is that this is the tip of the iceberg, and what else is going on? But what I don't know is that normal clinical practice? Because I've not done a generalist caseload in so long.
Look, I'm burst. I said I've got my thoughts on this, and I'll say them later. Like, I'm bursting now. So I'm going to burst. The main thing I'm going to reference and hopefully link to is I did an editorial, if you recall, a number of months ago, called "Self-Flagellating Peacocks." Does it ring a bell?
Yeah.
And the general premise on that was this idea that unfortunately we have a number of people that are irritatingly far ends of a spectrum, where you've got people that are over-reflective to the point of anxiety, that would hear even this discussion and what they would hear is, oh, I'm not staying in my lane enough, or maybe I'm staying in bed. They immediately will put that on themselves. Could I be better? They're the self-flagellators. And they're the peacocks. Then those people that are being really cavalier with these variables in terms of both safety and quality, and they'll just have a go. And one of the dangers, I think, and the reason for that existing, is that we don't have these clean lines that would help people to navigate this map. So, for example, on some of the things that we were talking about earlier, that ACL thing that you were describing is that there's no hard and fast evidence that those thresholds are necessary and mandatory. It feels cavalier for me when someone is trying to rehab an ACL when they've no access to anything beyond red TheraBand in a side room above or next to a hairdresser's. It's just, I remember those days, and I remember that those aren't appropriate ways of managing these people. Arguably then you're a consultant of which is then advising them on gym programs of which they might have access. But as a general rule, there is no hard and fast line on an evidence-based way that would mean that, well, how are you going to appropriately test their 80% of their quotas return? It's like, no, we don't know that prognostically. Like, there's enough vagueness there in the system for us to not know. Similarly, with regards to someone spotting and managing a diagnosis of stress fracture and things like that, it's just that these things are irritatingly vague sometimes. So I don't think sometimes it's the evidence will provide the structure that would help us to say this is where you crossed the line.
Certain 100% of the time.
So again, it ends up in this situation. What we're begging of ourselves and our colleagues is to start to work on those muscles that help you to recognise some of the nuances there. Create a network of which you can get a peer second opinion, even if it's not a specialist second opinion, as a means to make sure you're not isolated. So you're not being the peacock that's just blagging it, but you're also not then indulging this idea of it being like, oh yeah, good point, and I best err on the side of caution, because some of that caution and anxiety that sometimes people over apply to themselves isn't healthy either. And I think that as an industry, that's why I said we are self-flagellating peacocks, is because those two things are so contrasting, never really embodied within the same person typically. But as an industry, we are not regulating that well amongst ourselves, and that this is the sort of discussion that needs to be had. It doesn't have a clean answer to it though, and as I've mentioned before several times, we are left at the discretion of the ethics of individuals rather than us having any sort of mechanism of which we can better regulate ourselves, and that is a worry. I know it doesn't drive us towards a solution to this, but had you guys, when thinking about this more, longer than I have, had you thought about what would be ways in which that would be best done, or was it just provoking that conversation to see where it went?
Yeah, it was a bit to do with provoking the conversation, but I feel like it's partly social media issue in that it's obviously brilliant. We have so much access to various people. But it's also, you have access to various people. And I in these situations, I feel like this posting the information and asking for advice is a vague way. It's a too vague way of doing it. Like, you don't know what response you're going to get, or if you're going to get a response. I feel like you need a better network than that. So you need to be able to pick the phone up and ring someone specifically.
So people are casting their net too wide.
And it's like, you don't necessarily need, this person's got a rheumatological problem, I need Jim's phone number. That, I don't think that's necessary.
I'll stop giving it out.
Why do people keep ringing me? But it's more like I've got a peer, someone who I have a rapport with, who I can have a conversation with, and we can come to a conclusion that, okay, yes, I between two of us, we've got a buffer that, yes, this is worth me doing 1, 2, 5 sessions of whatever before we reconvene, or no, actually this should be sent out somewhere else, or I shouldn't see them. Like, there isn't anything to stop the social media post as well, but if it's only the social media post, I think you might as well just not bother, because it's just like you say, casting the net too wide, and you're not asking a specific enough question. When I teach on rheumatology, I tell people, if they're going to investigate, they need to know what they're investigating and why. You ask a question because you want an answer. You don't ask something vague because you will get vague,
like in imaging, right?
Correct. You don't go, if you've got
image the foot, they've got some pain. I'm trying to rule out this.
Yeah, exactly. Good.
Do you think in terms of managing and running teams and businesses, you're partly triggered by this because you know that when someone's being that vague, your spidey senses are going off on the fact that they just don't necessarily know what they're doing? That you said it's the tip of the iceberg and stuff. Because we know that when someone's presenting a case, if all they're giving you is, ouch, your foot not done well to rub, then you know that they're kind of lacking the specific skill set.
Exactly. And I think that, but we don't know what you don't know. And I think the more competent clinician is the one who will actually probably refer more. And if you look at, might not be the easiest example, but orthopedics, in terms of the medical side of it, they'll very much stay in that lane, and they are then uber specialists in that, and they are not generalists at that point, but they have those divisive lines between, okay, I do knees, is it in a knee? No, cool, you need to go elsewhere. And it's a little bit more, don't have that. But I think that, I am far more confident now than I was 13, 14 years ago, saying, actually, I can help you, but I also have a much wider network and a much wider team. So it's learning now that actually this is what I can help with, and this is what I can't help with. And that has taken years, and I think it will take everyone years to help with.
I think where I've realised that I can't tolerate it at all, and I think it's dangerous, and I honestly get quite animated enough to wish that there was some form of repercussion, or someone could literally give these people's heads a wobble, is when it involves children. So when someone is then saying, this is a patient's son that came in, they asked me to have a look, right? So MSK classic. This patient's son is in towing or whatever, and they'll put a picture in, or what do you think about my niece's limp? That starts to be, or especially if it's someone that's just giving something a whirl, and it also then just, for me, so often unearths a degree of broader incompetence, because there'll be something like someone they present a child who's got what looks like a tonal issue, or could be a tonal issue. He says as an paediatric specialist, but I'm just meaning especially I'm married to one. Especially when we've both had eyes on this. We'll say we've both had eyes on this. We're both mortified at the fact that someone's going, what should I do with this? Yeah. And they'll then say, I've tried an orthosis, as in a classic normal in shoe orthosis, and some clamshells for an 8-year-old who's got this what looks like increasingly neurological presentation, of which part of what you're doing is you're delaying diagnosis, but again, usually it's because you've then thought, well, we technically see children. Assume you would see musculoskeletal children if you're not able to then differentiate those, especially at those ages, because there's something seeing teens still specialised, but seeing younger than teens even next level with regards to that differential diagnosis. That's where I've mentioned before, these areas where I'm really open to the fact that people are chancing stuff, like even with ACLs and stuff like that, right?
Or the principles are quite similar, right?
Yeah.
But that goes back to management rather than diagnostics. So if you have a confirmed ACL, the management of that, yes, you could probably extrapolate. You could print off a protocol online and you could follow it.
And it might compromise best practice, but you'd still be
and similar with.
But you can't have a go where a child who might have CP.
It's similar with what we said about the inflammatory arthritis. The example, if you've seen rheumatoid arthritis patients before and you get a lupus patient. Yeah. You're not going to go miles wrong. Do you know what I mean? You're not going to be like,
they've got confirmed lupus.
They've got confirmed lupus. Or what on earth are you doing? That's insane. Like you're not going to be that wrong. Yeah. But like you say, then it's these downstream effects of other things. Yeah.
So I think the diagnosis for me is the most important part. And you can never be certain with anything, but you can be fairly confident enough that A, you know what you think is going on, and B, you know what to look out for. Like with that foot pain. Are you confident enough to say that actually I've considered 30 things that it could be, and I'm pretty confident this A fits with an MSK, and B I have considered a stress fracture, and you've considered all those things that it could be. You can never guess 100% right. But if you looked at who's a good example of someone who's a very good SEM doc, they're very generalist specialist at the same time. They are very good in that world of recognizing, staying where they're laying. Now they are doctors at the end of the day. It's a whole different area, but ultimately their caseload is probably very similar to our caseload.
And I think that is something that's animating me and animating some of our plans at the moment. And so for those that are a bit of a spoiler for Chewy and Jim listeners and viewers, is that we're really seriously considering what our role is in creating competency frameworks that would not. We've always been of course you should be working within local competency frameworks, and that would make sense. Increasingly not existing in and out of the NHS, people becoming increasingly siloed means that maybe we have a role there, which would be interesting for us to explore. We've got some content that further takes this conversation forward with Physio First planned, haven't we? Which will be really interesting to see and get more voices and more takes on this, because we've got our instincts, some of them shared, some of them slightly contrasting, but as a general rule, it's something we know that we're never going to drive to a solution in this pod, because it's more of a talking point as to there's so much reliant on people's instincts there. And instincts are important things, but generally speaking, there's no way that we, across many generations of therapists, across many different disciplines or different degree courses and stuff, is unlikely that we're all going to have that shared instinct that probably needs to have at least a backup to, doesn't it? So, any further final comments?
No.
Anything else to add?
No,
well, and you're welcome to infiltrate again, Rob.
Thank you so much.
Thanks, lads.
Chewy, Jim and Bevan.
Chewy and Jim, chatting along on their old pod feed. Chewy and Jim, HR keeps them afloat. We go to play and have a look with Chewy's gags, Jim's dashing looks. The world wishes their views were tame, so Chewy and Jim just take the blame. Chewy and Jim, just get